HRT. So what we're going to do, a little bit of an overview, some case discussions, some questions, and we're really going to be thinking about things like which HRT, if you're going to prescribe it, how to prescribe it, formulations, some pros and cons, and some useful resources for clinicians and patients. So over to you for a moment. We're going to do a poll in a second. So imagine this is an opening gambit. Hi doctor, or hi nurse. I've come about my menopause symptoms and I'm really hoping that you can help me. So just holding that thought in your mind, I'm just going to launch a poll and just want you just to vote, thinking about how people feel about menopause and HRT at the moment. Okay, excellent stuff. So I'm just going to share what you thought. So good. People are here because they want to learn, which is all good. Nobody is going to say that they are an HRT expert and know more than I do. I hope that you probably all know a lot more than you think I can. And I'm hoping that anybody who is in the I want to jump out of the window group is going to, by the end of this session, feel a little bit more confident and capable with HRT and the menopause. So really, we're just going to upskill you and improve confidence, because sometimes it is a confidence thing rather than not. You might be that you do actually know enough, but you might think you don't know enough. So a little bit of a whistle-stop tour and summary of HRT. So I think one of the purposes of doing this was talking about, can we actually get people working a bit better together across the PCN and get people to know each other. So as a result, I have got a question for you. But I'm going to send you off into breakout groups of 3 so that you can actually spend a couple of minutes meeting somebody that you might never have met before, and also answering those questions. So just thinking about that, what are the 3 main sorts of HRT? How do you deliver progestogen and why? And just a little bit of meeting one and other, because I think that is useful as well. So I'm just going to create these breakouts. So bear with me a minute. So right, so off you go for about 5 minutes or so. We'll call you back in. So this is going to work. So coming back to thinking about HRT, different sorts. So 3 sorts of HRT. Some people might argue that there's sort of 4. And we're going to talk a little bit about topical estrogen for GSM, which is the sexy new name for vulval atrophy. So we'll come back and talk about that in a bit. But thinking about systemic HRT, 3 sorts. So estrogen only for women who have had a hysterectomy. So if you have got a womb, you always need progesterone. So if you learn nothing else today, and if you want an audit to go back on, it's often a really useful one to do. actually looking at HRT prescriptions. I know people who are using Eclipse Live actually does, I think it's one of the things that comes up on Eclipse Live as well. You know, this patient is on estrogen only HRT and is not coded as having had a hysterectomy. So it does help you. But yeah, if you have a uterus, you need progestogen. So estrogen only, cyclical combined, which is estrogen with progestogen for part of the cycle. Continuous combined or no bleed HRT, which is continuous estrogen and progestogen. And like I said, also we'll talk a little bit about topical estrogen, which I don't think does count as HRT, but some patients believe it does. And I think we're talking about menopause and menopause prescribing. It's relevant to talk about it in a bit. So estrogen only, no uterus. Comes as a patch, it comes as a gel, it comes as a tablet. And you can have tablets 1 milligram or 2 milligrams. The main formulary one is LS Solo, though I know it's been out of stock. And I think that's one of the things that's made HRT prescribing over recent months phenomenally stressful. It's not just COVID, it's the fact that for some reason, all our favourite HRT preparations aren't available. And HRT tends to be something that gets prescribed by brand. So then it gets really frustrating when it's out of stock. And this is where I'm going to make her blush. She's got a camera off, where Jess, our wonderful PCN pharmacist, is worth her weight in gold, as she sends a task going, by the way, this one is this one, or this is what you can prescribe instead, or whoever has got this back in the wholesalers. So it's worth knowing, because otherwise it can be a bit of a nightmare. So patches, usually applied a couple of times a week. Gel, again, is also an option. And for people who prefer topical estrogen, interestingly, if you've got really sensitive skin, you've got quite bad eczema, the patches are often a nightmare because the glue can often really upset people's skin. The gel seems to be less of a problem. So if people want topical estrogen, it can be worth thinking about gel if they're wanting it topically and they're really struggling with the glue with the patches. Generally speaking, once you started HRT, you're going to review it after about 3 months. And interestingly, if you look at all the guidelines and look back through the BNF and the Faculty of Sexual and Reproductive Healthcare guidelines and the RCOG Green Top guidelines are nice. They all say if you have focal migraines, transdermal estrogen is definitely okay, but there is a bit of a question around tablets. So again, that might guide your decision on what preparation you're going to use. So combined HRT, you need your progestogen. Your progestogen will protect the endometrium from proliferation, dysplasia, or going on to an endometrial CA. So just thinking about that, how do we deliver this progestogen? So does anybody want to volunteer one route for delivering progestogen that you managed to come up with in your groups? Everybody's got their camera off. I can't really pick on it. I'm going to assume you're there, so I'm just going to, I might just start shouting out names. That's not really mean. Jan's turned her camera on, so she gets the option to have her name shouted out because she's turned on her camera. So do you want to tell me one option? So do you want to unmute yourself and tell me one option for delivering progestogen?
Oh, you can use the Mirena coil as one way of delivering progesterone.
Awesome.
Am I right? Yeah.
Absolutely. Mirena, brilliant option. Okay.
Now, if you were doing that, Tara, would you use the Solo, the estrogen only, and then the Mirena?
Absolutely. So estrogen only and Mirena, and we'll come on and talk a little bit more about that in a bit. But that is probably the best and safest HRT. Is probably a Mirena and transdermal estrogen of some sort. So we'll talk about that in a minute. So if they don't want a Mirena for some reason, or you haven't got access to anybody to fit a Mirena, what other options have we got to deliver progestogen? So somebody's put on the chat, Naren's put on the chat, micronized progestogen capsules. Absolutely. Can you remember the name? Remember? We say oral progesterone, and with those Utrogestan, fantastic. So we might use a Mirena, we might use Utrogestan. Any other options? We've all drawn a blank, have we? Right, well, let's go on and have a little think. So Mirena, Or, so the thing about Mirena I was thinking about is it's also a contraceptive. Now, the thing that's always worth remembering with Mirena is it's licensed for 5 years for HRT, for endometrial protection. When you're using it for contraception, the advice is always, if it's fitted over the age of 45 for contraceptive purposes only, you can leave it in until you are sure they no longer need contraception and then take it out. But as soon as you start using it for endometrial protection, that 5 years starts ticking along again. And I think most of us that are fitting intrauterine devices are getting back towards a relatively normal service of fitting. It's something that the Faculty of Family Planning were very clear to point out through COVID, but if people had a Mirena for contraception, even if they were under 45, oh, don't worry, leave it another 6 months, leave it another year, it's okay. They were very clear that for HRT, we needed to give people some additional progestogen. So it's just worth thinking about that. 5 years really does start ticking by again if you're using Mirena. So if we're going on to tablets, safest option is utrogestan, which is micronized progestogen, though you can use other progestogens, and there are combined HRT tablets, but most are out of stock. Good point, Natasha. So the license on Mirena says 4 years. The Faculty of Family Planning and NICE and the RCOG have all said 5 years is okay for HRT. If you're using a Mirena. So the product license in the box may still say 4, but the faculty have said they're really happy with going up to 5. So I'm going up to 5 with all of mine because I think well supported by faculty guidelines in doing that. You can, it's unlicensed, but we're thinking about, you can use utrogestan, micronized progestogen PV. And you might say, well, why on earth would you want to do that? But actually, if some people just don't like the idea of taking tablets, or they're not very good at swallowing tablets, or they find that they get nauseated, or they've got some kind of gastric absorption problem, it may be worth doing. It's unlicensed, but it is recognised. So again, they can do that. And I have a couple of patients who bizarrely are like, I know you're going to tell me not to, but I just put my progesterone, I use my progesterone intravaginally, I use my utrogestan that way. I hope you don't mind, doctor. And I go, well, it's not licensed, and document it, and on we go. I've never really quite understood why they want to take it vaginally, but they do. Just really worth thinking about the fact that Depo, progesterone-only pills and Nexplanon cannot be used for endometrial protection. Now, clearly, you've got a really whacking dose of progestogen in Depo, and most people who have Depo have really, really shrunken endometriums, but it's not licensed. So you can't think, oh, they're on Depo, I'll just give them estrogen-only HRT. It's not licensed, and it is not recognised as a reasonable unlicensed thing to do. But they are good contraceptive choices for women needing contraception in and around the menopause, though I would argue Mirena will solve all of the problems. So, cyclical combined HRT. So if it's less than 12 months since their last period, you're going to use estrogen for the menopausal symptoms and progestogen for 10 to 12 days of the cycle to induce a withdrawal bleed and protect the endometrium. So you might want to use a combined HRT regimen. You might want to use a patch with 10 to 12 days of progestogen in the cycle, or you could put Mirena in, and obviously then that's not cyclical, but it doesn't matter. So if somebody says, oh, I don't think I'd get on with taking it some days and not taking it other days, and I don't really know what to do and I don't really understand, again, they may well be somebody who would be better off with a Mirena for their endometrial protection. Continuous combined no bleed HRT is only licensed 12 months after their last period or after 12 months of cyclical HRT. Now, I will admit that actually if somebody comes and says, I've not had a period for 11 months and I'm really struggling with all my menopausal symptoms and I really, really want HRT, but the thing that's put me off is I really don't want periods, I probably would have a full and frank discussion with them about the fact it's not licensed and that they might bleed, and then just go, let's just fit you, let's just get on with it, let's give you some HRT, let's give you continuous HRT anyway. So I think that's just worth being aware of, but it's not licensed. And again, Mirena with a patch is probably the safest option, particularly when thinking about breast cancer risk, but you can use continuous combined HRT or a patch plus daily utrogestan. And I just think when thinking about tablets, the thing I always remember on old formulary, if you are thinking about prescribing, and hopefully all these will come back when thinking about tablets, is LS, which was our main formulary choice, is really easy to remember. LS solo, solo being only estrogen. LS duet, two things in it because there's a duet between the estrogen and the progestogen. Duet conti is continuous, so two hormones all the time, LS duet conti. And who knows whether that's why JPAC put it on the formulary, but it's easy to remember if you can get hold of it, which I know we can't at the moment. So I'm going to send you off again, think about side effects of HRT. Because patients often say, what will the side effects be? Or I don't want it, or what's going to go wrong? What are the awful things that might happen? So just thinking about that, side effects of HRT. So I'm going to send you off into breakouts to have a little think about that. Come back and start thinking about some side effects. So, bear with me a moment, sorry. So, side effects of HRT. So, we're thinking about them as estrogenic and progestogenic side effects. And one of the things I always think about is almost worth thinking about, if you think it might be an estrogenic effect, it might be a symptom that you could imagine being a problem in early pregnancy. So fluid retention, nausea, headaches, breast tenderness, leg cramps, which don't really fit in with anything, but I just think those sorts of, oh, I feel a bit sick, I feel a bit bloated, a bit headachy, I've got sore boobs, that's probably the estrogen. And it can be worth lowering the estrogen dose if for some reason you've gone all gung-ho and gone in at 2 milligrams, or swapping to a patch or a gel if they're having tablets. Progestogenic side effects, again, normally transient, will usually subside after 3 months or so. And again, those are sort of more PMS type, PMS bloating sort of symptoms that you might imagine getting with somebody on a progestogen-only contraceptive, perhaps, get those sorts of symptoms. And again, it's just worth thinking, if they're getting lots of progestogenic side effects from tablets, it might be worth swapping over and thinking about transdermal, vaginal, or Mirena for your progestogen. So people often then say, what about breast cancer? And I think that's just worth thinking about the fact that going back through the data again and again, it is thought that probably estrogen-only HRT people do not have an increased risk of breast cancer, but over their background risk. But of course, if you've got somebody who has got an estrogen-dependent breast cancer already, or a catastrophic family history of breast cancer, the risk of any HRT, of any estrogen, may be too high. But if they haven't got any other risk factors, and they are only needing estrogen-only HRT, the risk is likely to be very low. There probably is a risk if you take estrogen and progestogen together, but that risk is increased. It's interesting. The magnitude is probably the same as the risk of breast cancer for women who are drinking 1 or 2 glasses of wine every night, or being overweight at the age of 50. Now, the problem is that a lot of women will be overweight, having a glass of wine every night, and then wanting HRT. But it's just worth thinking about the magnitude of the risk, because actually our patients and we are probably quite good at going, oh my goodness, this thing I'm going to prescribe you might be causing you problems, and less good at addressing the lifestyle factors around it. So if you do need to use combined HRT, the lowest risk from a breast cancer perspective is transdermal estrogen and a Mirena, or transdermal estrogen and micronized progestogen, that is utrogastan. So, contraindications to HRT. I was going to say breakout, but actually just not very many of you. So thinking about contraindications to HRT, do you want to put on the chat anything that you think is a contraindication to HRT? Stroke, okay. History of breast cancer. Any more for any more? Okay, so got you thinking a bit. Absolutely. So there's not very many contraindications to HRT, and some of them just make me laugh. Pregnancy. I'm not entirely sure why we would be wanting to give HRT in pregnancy, but it's worth thinking about the fact that, of course, if somebody is amenorrheic and feeling a bit rubbish, it's probably worth making sure that they're not pregnant before you ascribe their amenorrhea to menopause. Undiagnosed abdominal vaginal bleeding, so active thromboembolic disease or acute phase MI. So they are contraindications if you are some time down the line, depending on their ongoing risk factors, depending on other things. It is not an absolute contraindication, but if somebody has actively got a DVT or PE, suspected or active breast or endometrial cancer, a previous estrogen dependent breast cancer, because if you've got non-estrogen dependent breast cancer, it doesn't make any difference. So actually, that's one of those things it's just worth thinking about. Just because somebody has had breast cancer, if it was definitely estrogen receptor negative, they are at no higher risk of anything if they are given HRT. Active liver disease with abnormal LFTs, and then one of those brilliant textbook randoms that I've just left in because it always makes me laugh. How many patients with porphyria cutanea tarda have you looked after? Because I certainly haven't looked after any, but it is a contraindication. I think poor old people with porphyria can't really take anything, but you know, that is there too. So, few words on GSM, which is the new name for vulval atrophy. So, about half of women after the menopause. And the thing that's just really worth thinking about is if somebody's got awful vasomotor symptoms, they will eventually wear off. So they may have a really, really tough time and then it will settle. Your vulval symptoms will never get better. They will probably get worse. So where you might decide to make a decision with your patient that their hot flushes are manageable and actually let's just wait because they will burn out and get better eventually, though that might take 5 years or more, their vulval symptoms are not going to get better. So if they are really troubled by vulval symptoms at 49 or 50, when they are 70, they are still going to have awful vulval symptoms. So, you know, it's really worth treating. So we're thinking about vaginal dryness, dyspareunia, postcoital bleeding, vulval discomfort, itching, burning, urinary frequency, urgency, nocturia, recurrent UTIs. So your women with recurrent UTIs, actually have a look. And if they keep getting UTIs and you look and they are a little bit grey and shriveled up down there and really sore and haven't had sex for 5 years because they say, I had a lady the other day who came to see me and she said, this is going to sound so weird, doctor, but I think my vagina has closed up completely and it wouldn't matter. Only I've met a new man and I think I want to have sex and I can't work out where my vagina has gone. Bless her. She got tons better with some topical estrogen. But it's just worth thinking about actually how bad is it before they've come to see us. Stress incontinence as well. And the reason you get recurrent UTIs and stress incontinence is partly to do with the effect of estrogen on the urethra, on the pelvic floor, and the little periurethral fat pad which holds your urethra up. So if that's atrophied away, you've essentially got this almost open, quite patulous urethra, which can then take on bugs from the perineum really easily. And also it's much harder with some pelvic floor contraction with their not very good pelvic floor, because the lack of estrogen means the pelvic floor is not working very well. The urethra is more open, they can't close it off properly, so they are then more likely to leak. So we manage that with topical estrogen, so mostly via pessary or gel, though maybe via vaginal ring. And I've got a few patients who quite like vaginal ring. Vaginal rings can work quite well, the estrogen vaginal ring, if they are going to struggle to apply it themselves. So I've got a couple of quite disabled elderly ladies who the continence clinic have trained up some of the district nurses to change vaginal rings, and it means that they can change their estrogen vaginal ring. And I can never remember how often you change them. If anybody knows, that's brilliant, you can tell me. But it's just worth thinking about that as an option if their carers would not be able to use vulval or vaginal products, putting them on. You're not necessarily going to be able to get the district nurses to come every day to do it, but actually once a month to change your ring may be an option. And I've got an elderly lady who has a vaginal ring with estrogen, and who used to have UTIs probably at least every couple of weeks, and she now almost never has them at all, because it's made such an enormous difference to her, and to her continence as well, because actually she was being toileted only when the carers came, which of course does increase her risk of UTI, but also that worry about, I can't hold on, I'm going to have to wear a pad, I don't know what to do. Now quite often she can hold on, and that's made an enormous difference to her self-esteem and her quality of life as well. Of course, if you need some HRT for vasomotor symptoms, that will help genitourinary symptoms, but you can use the two together. And actually, if somebody hasn't got vasomotor symptoms, they've just got vulval symptoms, vulval estrogen is probably the answer. And interestingly, NICE doesn't make any statement on lubricants or moisturizers, but they may well be worth thinking about, particularly if the major issue is dyspareunia. If you've got a uterus and you are using vulval estrogen, should be no more than twice a week as a long-term thing. If you have had a hysterectomy, you can use as much topical estrogen as you want. And so that's just worth thinking about as well. And I generally say daily for a couple of weeks, then every other day, and then once or twice a week as a long-term thing. And I would usually aim to review people at about 6 weeks after having started some topical vaginal estrogen. People often ask about testosterone. So little slide on testosterone here. So testosterone does come into the NICE guidelines, NG23. So low dose testosterone can sometimes be beneficial at improving energy, mood, concentration, and libido. It doesn't help everyone, and it's not licensed. Use a gel daily, and it can be prescribed on the NHS. It says if the prescriber is familiar with it and willing to prescribe it off license. Some prefer not to take this decision and refer to a specialist for advice before prescribing. So it's just then we're thinking about, actually, how do you feel about testosterone? And would you feel able to do that? Is there somebody in your practice who would add in testosterone? Because if not, they're going to need a referral. And as you probably all know, Wheatbridge no longer do menopause referrals. So Amanda Smith, who was the person who led the menopause clinic at Wheatbridge before it was decommissioned, has gone off and is seeing patients privately and is running a menopause private clinic. I can't remember what she's calling herself, but she advertises in like Reflections magazine and all sorts of places, and is running her private menopause clinic. So if patients can afford to go, they could be sent privately to see a gynecologist or see Amanda, or if you want to refer them NHS menopause clinic, you're probably going to end up referring to Sheffield or Derby, because the ordinary gynae outpatients at Chesterfield aren't really set up to do any more complex HRT than, oh, you've had a hysterectomy, you've had a hysterectomy and you had your ovaries out and you're 25, you might want some HRT. That's kind of mostly their level, really, in terms of their interest in specialised HRT. But we don't have menopause clinic at Wheatbridge anymore. I got decommissioned about 18 months ago. And another option might be to prescribe Tibolone, which has some androgenic effects and can help with some of those symptoms. So I'm going to think about some cases now. So case one, Leslie. So Leslie's 52. She works in the job centre and she presents with several months' history of struggling at work. She feels she's not coping because of poor concentration. She's exhausted. She wakes up in the night having hot flushes. She can't get back to sleep. She's really emotional. And she acknowledges on several occasions at work she's had to excuse herself from her frontline role and hide in the toilets to cry. She's struggling at home because she snaps at her teenagers who drive her mad by never loading the dishwasher or tidying up. Her husband has encouraged her to see the GP as their relationship is suffering. So, what other things would you like to know? So do you want to stick some ideas on the chat about what else you want to know about Leslie? Periods, brilliant. Yeah, is she still having periods? Anything else you want to know? Okay, has she got a uterus? Is she on any medication? Has she previously had depression, mood problems? Absolutely. Medical history, breast cancer, family history. Okay, heading along some reasonable lines, thinking about this. How about good old general practice, ideas, concerns, and expectations? What does she want? What is she expecting you to do? Actually, does she actually want to disappear off to a Greek island and have a romance with somebody else? Is she actually fed up of her husband? You know, her husband sent her along. What's actually going along? You know, what's actually going on here? And what does she actually want? Has she come wanting HRT? Does she want you to tell her that this is all normal? Does she think that she's depressed? So yeah, what else is happening for her? So she tells you her libido is non-existent. Last period was 10 months ago, maybe even longer. But the only good thing about what's going on at the moment is that she's not having any periods, and says to you, is this the menopause? What do you think? Is this the menopause? Yes, no, maybe. Brilliant stuff. So yeah, it almost inevitably is, but it is not yet the menopause, because you have to be 12 months from your last period to be called very definitely the menopause in textbook definition. Are these all menopausal symptoms which can be ascribed to her ovaries having given up their useful function? Almost undoubtedly, yes. So Leslie says she's not really keen on the idea of hormones because they're not natural. And she wants some advice about natural management of her symptoms. So I'm going to, again, make you do a little bit of work here and send you off again to think about what lifestyle advice do you give your patients? So what is good lifestyle advice for managing menopausal symptoms, and how do you answer the question about HRT being? So back to our lifestyle things. So this is quite a wordy slide. I'll let you all have it all afterwards. It's all on here. So this is here to send out later, rather than because I'm expecting you to read it all. I'm not going to read it all out, but exercise. So that's really worth thinking about. Regular exercise from a mood perspective, and also for bone protection. So remembering that weight-bearing exercise will reduce the risk of osteoporosis. And once you have hit menopause, your estrogen levels go down, your bone density starts to decrease. Pelvic floor exercises. Arguably, we should be telling all women always to do pelvic floor exercises, but really, really important actually at this stage to be encouraging people to do regular pelvic floor exercises. Well-balanced diet with plenty of calcium, again thinking about bones, and reducing saturated fats, and starting to think about cardiovascular disease risk, because once you stop producing estrogen, you develop a more male pattern of risk with respect to ischemic heart disease. Alcohol, so actually thinking about reducing alcohol, and recognizing people will sometimes say, oh, well, red wine, it reduces your risk of heart disease, and in minimal quantities possibly does. But particularly if people are getting lots of flushes and palpitations with their hot flushes, actually alcohol can make that significantly worse. Vitamin D, getting outside, fresh air, endorphins, and counselling can be really helpful, because actually for some people it's this overwhelming transitional phase, this sense of loss, this sudden realization that actually their childbearing days are over. And everybody else might be saying to them, oh, for goodness sake, women, you're 50. Of course you can't get pregnant again. But actually a grief reaction is not uncommon. So it's just worth thinking about the fact that actually some people may need some help to get through this phase in their life, because actually it does represent quite a big watershed moment. And there may well be a lot of other stuff going on as well. And their menopausal symptoms are perhaps the thing that is tipping them over the edge. So specific symptom management. So interestingly, there is good evidence for CBT for some vasomotor symptoms. So there's some really good evidence that it works. And it seems a bit strange, and patients often like, what do you mean CBT? How on earth is that going to work? But it can help. If you've got moderate to severe vasomotor symptoms, they may benefit from some other drugs. So there is some evidence for SSRIs. NICE is very clear, saying don't just put them all on antidepressants, don't assume all mood disturbance around the menopause is depression, and I think that's worth considering. But actually there is some evidence for SSRIs and SNRIs, as well as some good evidence for gabapentin, pregabalin, and lesoclonidine, which is our sort of historical has been used drug. I think works in about 1/3 of women with hot flushes. So it's worth thinking about it, especially if they don't want hormones or there are contraindications. And of course, we've got to think about gabapentin and pregabalin, which do work, but actually obviously are now controlled drugs, and there is significant risk of abuse and misappropriation of them. Really basic lifestyle advice can be really important as well. So wearing natural fibres, sleeping with layered bedclothes. The Chillo pillow, which was designed for use for people having chemo to stop hair loss, can actually work really well to keep head and neck cool. So that might be worth thinking about. And again, thinking about topical vaginal estrogen if their major symptoms are actually vulvovaginal. So 6 weeks later, Leslie comes back because she decided that she was going to go for long walks and get some fresh air and consider some self-referral for some CBT. But she comes back and everything's worse. And now she's had a verbal warning because she snapped at a client. She's sleeping for 2 hours a night and she feels absolutely awful. So what are you going to suggest now? Stick your answers on the chat. HRT, absolutely. Now is probably time for HRT. So, time for HRT. But she's worried because HRT is dreadfully cruel and involves abuse of horses. Is that something you've heard before? Anybody come with that? Remember the first time somebody said that to me, I was like, I have no idea what you're talking about. I do know now. Familiar comment, worry from patients? Nope. Okay, so just worth thinking about. So there are equine estrogen preparations. So the classic one being Premarin, which is Premarin. But the vast majority of HRT is actually synthetic and it's not made in this way. So it's just worth actually talking to them about the fact that the vast majority of the HRT preparations that we would actually be prescribing are synthetic and are not from pregnant mare's urine. So we also established that she wants HRT, her husband's had a vasectomy, she doesn't need contraception. What HRT are you going to start? So a couple of people have come up with some things. So a couple of people saying cyclical. Anybody want to disagree? No. Just worth thinking about the fact she came to see you 6 weeks ago, having not had a period for 10 or 11 months. So she's almost undoubtedly now 12 months post-menopause. And the thing that she is happiest about, or the only good thing about her current situation, is not having periods. So actually there is no point in putting her on cyclical combined HRT. She's so nearly 12 months, or probably is 12 months, that actually you could go straight on with a no bleed HRT. So she needs continuous combined and estrogen for the symptoms and progestogen to protect her endometrium from proliferation plus or minus cancer. So I would probably go for a patch with Utrogestan or try and persuade her to have a Mirena, but she may well say to you, no, my husband's had a vasectomy, I really don't want messing around with that. But patch plus Utrogestan is probably going to be the best and safest method of giving her HRT. So next case. So Jane is 41. So she had a hysterectomy and a BSO last year for severe endometriosis, following which she's been taking Proginova 2 milligrams. She's struggling with hot flushes, but her main symptom is marked lack of libido and superficial dyspareunia. So is Proginova the best HRT in this situation? And if not, why not? And what else might you consider? So again, I'm going to send you off for a couple of minutes to have a think about that. So I think we are all back. So, Jane, so it's kind of obvious, perhaps, question, is Pro going over the best HRT in this situation? Well, probably not, because she's really horribly symptomatic, isn't she? So it's clearly not working for her. And the other thought is, of course, she's had severe endometriosis. So there is some evidence that if you have got lots of endometrium stuck down all over your internal organs, if you give estrogen-only HRT, you do run the risk of getting an endometrial carcinoma from an endometriotic deposit. So you haven't got an endometrium, but you could still end up with an endometrial CA. And I saw a lady with that when I was a gynae SHO, which has made me quite anxious. Generally speaking, if people have really severe endometriosis, they tend to get given combined HRT at least for the first couple of years. So that's just worth being mindful of. So what might we want to use? So she's got low libido and poor energy levels. So you might want to add in some testosterone. You might be a bit worried about what's going on with her endometrial lining or her ectopic bits of endometrium. But actually, it may well be really worth thinking about tibolone for her. So tibolone has got some androgenic activity. And a lot of the time when they have ended up having hysterectomy in this kind of scenario, they get put on tibolone anyway. But that might well be worth doing. And perhaps if you're not really confident in prescribing HRT and you're thinking, okay, oh, HRT, maybe I think I can do this. Oh my word. No, testosterone, that is just a step too far. Tibolone will probably really help her. And also might, buy you some time to be thinking about, okay, let's give you 6 weeks or 3 months worth of tibolone and then come back. And by that time, I might have got myself brave enough to consider using some testosterone. So last one before we finish, Amber. So Amber's 36 and she comes with 14 months of amenorrhea. She's got 3 kids who are 8, 6 and 4. And she doesn't want any more babies. She hasn't used any hormonal contraception since she got divorced 18 months ago. And she's really struggling with hot sweats, irritability, and feeling tired all the time. So have a think, stick some things on the chat for me. What else do you want to know about Amber in the history? What else are you going to ask if that's the beginning of the story? Yep, so a couple of people thinking down the line of actually, is she struggling, or her sweats and irritability related to her thyroid? So might well want to check the TFTs, absolutely. Anything else? So you might want to do some bloods. So periods, but we've just told you at the beginning, she's 14 months of amenorrhea, no periods for 14 months, so she says. Okay, any family history of premature menopause? Brilliant. Because age of menopause, the thing that is most likely to govern age of menopause is the age of your mother's menopause. So we do need to think about all of those things. Might think about some other things as well. So just thinking about differential diagnosis here. So she probably, is she having a premature menopause? Might she be thyrotoxic? Is she pregnant? She hasn't had a period for 14 months, but she may have been amenorrheic for 6 months and have ovulated just before she had a one-night stand and is now about to give birth. It's entirely possible. So actually she, just because somebody is divorced doesn't mean they're not in a relationship. Does she need contraception? What else is going on here? So what tests are you going to do? As we said, we might do some TFTs and an FSH. When are you going to do these tests? Does it matter? Any thoughts? doesn't matter, does it? You can do them anytime. Because she is now amenorrheic, you're not worrying about, is this day 2 of her cycle, is this day 21, like you're doing fertility testing. So check some bloods. So she's got a normal full blood count, a normal TFTs, but she's got an LH of 69.2 and an FSH of 42.1. So what's going on? What's happening to Amber? Yeah, so she's probably almost certainly got premature menopause, hasn't she? So this may well come as an enormous shock to her. I mean, she may well have already come and said, actually, do you think I'm going through the change? I feel rubbish. My mum had a menopause at 35. Has that happened to me too? But it may have come completely out of the blue. So, you know, this is a proper full-on Breaking Bad news scenario. Or assuming that that is what is, you know, that you're going to have to be really, really sensitive here because she's only 36. You know, yeah, okay, she's got 3 kids and she thinks she doesn't want any more children, but I think I don't want any more children is very different from, actually, you can't have any more children because your body thinks it's in its mid-50s and this is the end of your fertility. So you're going to have to be really sensitive and sensible, and also think about the risk to her of having gone through a premature menopause, and the fact that, of course, her bones are going to start decelerating in density. Her cardiovascular disease risk is going to go up. Her metabolic rate is going to plummet. So as you're starting to talk to her, she then says, oh yeah, I'm in a new relationship. Yeah, I've got this really nice new boyfriend as well, but I still don't want any babies. So is this going to influence the options that you explore with her, and how? I'm just going to send you off again to have a think about that for a couple of minutes. So just thinking, what you're thinking about now is, yeah, what options might you be going to explore with her, and why? Brilliant. So Pauline said, Myrina plus oral or topical. Absolutely, because she needs contraception, doesn't she? So she is 14 months since her last period, but she is under 50. So even though we think she's probably had a premature menopause, she still needs contraception for 2 years from her last period because she's under 50. Where if she was over 50, it would be 1 year. So she's a really, really good candidate for a Myrina with a patch. But you could also think, as long as she's not got any other risk factors, you know, if she is a slim, non-smoking, never had a migraine, no family of history of DVT person, she might actually want to use the combined pill for contraception and symptom relief. And yes, the dose of estrogen in a combined pill is higher than in HRT. But if she's 36, she's just got a new boyfriend, and actually she's not quite ready to tell him, actually, I've gone through the menopause. There is something very normalizing about having a packet of Levest in your bathroom cabinet when your boyfriend sleeps over, compared with having a packet of you know, HRT patches. So it's just worth thinking about the fact that actually you could use the combined pill, give her contraception, and actually abolish her menopause symptoms in one fell swoop. Because otherwise, if you're going to be using HRT, you are still going to need some contraception. And a Myrina would be absolutely ideal. So Myrina and patch is going to be a great option, but it's just worth thinking about the fact that she really, really doesn't want a Myrina. Just might well be worth thinking a little bit laterally and thinking, actually, you might just want to give her the combined pill, and then that would solve all of your problems and be a bit more normalizing for her.
How long would you leave her on that, Tara, if you did that?
Well, I suppose you could always leave it as long as you wanted, though arguably she probably then doesn't need any contraception after another 14 months down the line. Now you could kind of go, well, another 10 months and then change it. But if she hasn't got any risk factors for being on the pill, she could stay on the pill, you know, until she's 45 or 50, if that's what she wants to do. There'd be a reasonable option to do. So it's just really just worth thinking about it. And I've had a couple of young patients both of whom have ended up with one with premature ovarian failure and the other of whom had some pretty hardcore chemo for a teenage cancer, and both of them chose to have a 20 microgram combined pill for a long time before they were ready to tell their partner that actually they were never going to be able to have children, because they just said that actually the whole idea of having to have that conversation 6 or 8 weeks into a relationship was just too awful. And that to have contraceptive pills in their handbag or in their bathroom cabinet gave them back a sense of being young and normal until they were ready, that somebody was the right person to have that conversation with. So it's just worth thinking about. So before we come to the end, just thinking a little bit about resources. So there's loads and loads of resources out there, and these are my 3 favourites. Though when we were in the breakout rooms, I know somebody was talking about the patient.co.uk alternatives to HRT leaflet, which is also really useful. Rock My Menopause, which has got a terrible title, but is actually an amazing site. So that can be really, really helpful. Or the Women's Health Concern site, and they're both really useful. But I often send people off to go and actually have a really good look on Rock My Menopause and then come back to me. So I think that is well worth having a look at. And then Menopause Doctor, who is Dr. Louise Newson, who is a GP who is kind of branded herself as a menopause specialist, but who actually speaks brilliantly on the subject, has written some really, really good articles. And I find, I mean, this is probably a leafy Wingerworth thing, but a lot of my patients come having said, I've been reading Dr. Louise Newson and she's suggested this, what do you think? And actually it's usually incredibly sensible stuff, but it's just worth knowing about her, even if you don't ever signpost your patients to her site, because they probably will find her. And it's worth knowing she's got a pretty good reputation. She gave a big keynote at the RCGP conference last year on HRT and HRT prescribing and menopause symptoms, so she's pretty legit as far as a primary care menopause specialist goes, where we know some of the others might not be. And I think that's kind of pretty much the end of that, unless anybody's got any questions, recognising, of course, that I am a GP who happens to be female and sees quite a lot of HRT, but I am certainly not a menopause specialist, but I hope have delivered something that is approximately at the right level for other non-specialist people to start thinking about prescribing. So we have got a little bit of time if anybody has got any questions, if you want to ask. Absolutely feel free to do so.